Hi everybody! This is the fourth in the Facebook Live webinar series. So we're going to get started in a few minutes. Some of you may have noted that I've changed my surroundings. I'm in the living room, my kids are next door. So if they come storming in, apologies. And if we hear some crying, that's the kids. But usually I would be up in the office, but I think this background is a bit better. Hi Jonathan, hi Tom. So we'll get started in a few minutes. I've been really busy today. I was listening to a fantastic webinar with colleagues from the Eco Dental Group, which I'm a part of, and loads of associates and another 400 odd people, and we were listening to Finlay Sutton today, which was absolutely out of this world. So if you don't know who Finlay Sutton is, he is an absolutely fantastic prosthodontist based in Lancaster area, and he just does some world-class prosthodontics. Check him out, Finlay Sutton. So I was listening to him he went on for about an hour, but there was a Q&A, and he was so kind with his time and his knowledge. He spent about 40 minutes doing a question and answer session. So today what we're planning to talk about is the surgical features of delivering an FP3 bridge, and then some of the features that are what I look for to create the ideal FP3 bridge. So you'll remember when we talk about an FP3 bridge, what we are describing is, let me just turn this music down a little. What we're describing is the appearance. So it's the mesh classification from 1989, FP3, and it relates to the appearance of the restoration. And when we talk about full arch, when we mention FP3, we're talking about a restoration which is white and pink. So an FP3 is white and it's pink. Okay, and so what I'm going to talk about is the surgical features that I look to achieve to deliver that FP3 bridge in an immediate load case. So a few things I'm going to talk about. I'm going to talk about the flap, the alveoplasty that I do. I'm going to talk about degranulation and cleaning the sockets, which is really important. The fact that I place 4 to 6 implants. I look for a minimal, I will always aim for a minimum length of implant when we're immediately loading, and talk about the diameter and of the implant and when we're doing immediate loading. I'm going to talk about under prepping the osteotomy, talk about a minimal torque value, and then finally I'm going to just mention something upon how we always aim for a straight multi-unit as opposed to an angled, and why straight is better. Why a straight multi-unit is better than an angled multi-unit, but obviously, sometimes we don't have that choice. So flap, number one, flap, really important. You need to, build up that confidence to raise a wide flap for access and to visualize. So bystander protocol for a full arch is a full plato flap. I will always expose the nasopalatine nerve, and I will always expose up to the floor of the nose, and I will always expose so I can feel the bulbosity of the sinuses. So that's for the maxilla. Always expose the nasopalatine nerve, always extend as far back at least to the distal of the first molar, up to the floor of the nose, and I will always expose up so I can feel and potentially see the sinus lining and feel the bulbosity of the sinus. And having that anatomical exposure really helps with you placing your implants. So, and over time, there's no doubt that you can become confident in placing those implants without any radiographic images to help you. Just by visualizing and being aware of the anatomy, I'm confident that you can do that with practice. What about a mandible? When we expose the mandible, again, full flap up to the distal of the 7th if we're doing a lower full arch. I always look to expose the mental nerves, and we do a full lingual flap. A full lingual flap, and the way I test that I've exposed the lingual tissues enough is I should be able to get my finger down the lingual sulcus. So that's my test. So, and back to really need a good flap, a clean flap for visualization and for access, crucial. Then often, if there's no bone to remove, no teeth to come out, that's fine. But if there's teeth to come out, teeth come out. And I will always clean the socket. So either use some degranulation bars or use a straight hand piece with a round bar. Clean the socket's really important. Then often I will utilise rongeurs or some other bone crushing forceps and remove the bone. And often I will collect that bone and grind it in a bone mill, and often place that into the sockets. So I've mentioned degranulation. I will collect the bone. Alveoplasty. So there's a number of reasons to alveoplasty. One of the main reasons is for adequate restorative space in respect to that planned final restoration, but also doing an alveoplasty that's nice and flat allows you to build up, make a platform, making your implant surgery so much easier. So it's important. So that the alveoplasty, and then when your prosthesis fits on, it's going to be against a nice flat surface, which we'll go on to later. But it's so important, the fit surface of your FP3 prosthesis, how it fits onto the tissue, really important for long-term maintenance. For yourself as a clinician, and most importantly for the patient. Minimum length. Now the literature looks at lengths of implants in full arch, and they talk about all the literature that shows good success rates with a full arch treatment in immediate load. They look at implants that are at least 10 millimeters in length. So when I'm doing full arch treatment, I will always aim to place implants at least 10 millimeters in length. I'll always work with a minimum width of implant as well. So commonly I use the bi-horizon system, and I will rarely place an implant with a diameter less than 3.8. But the literature supports, with the strong evidence for success in full arch, is an implant that is at least 4 millimeters in diameter. Now that is certainly open to a discussion, especially with some implant systems really are they have implants that are stronger than other implants in terms of their composition. So there are some implant systems that I would be happy using a 3.5 diameter implant as if I was limited for bone, but generally I aim for an implant that is at least 4 millimeters in a diameter. And if you think about that, then I will always aim for a minimum of 6 millimeters in width of bone for me to do a full arch, because if my implant's 4 millimeters in diameter, then I want 2 millimeters on the buccal for long-term stability. Okay, so length, always aiming for at least a 10 millimeter length implant. Diameter, ideally at least a 4 millimeter, and these figures aren't plucked out of air. It's because that's what the literature supports. I'll always also aim for bicortical fixation when I'm doing full arch. That's so I can get high torque. And when I talk about high torque, I have a set protocol in terms of what a torque level I aim for before I then decide to immediately load. And I will always aim for a value in the region of 45. Certainly systems and other clinicians advocate lower torque, or some clinicians actually go even higher, and that's fine. Whatever works for you, that's okay, but I will always aim somewhere in the region of 40 to 45 Newton centimeters as a minimum if I was then going to immediately load. And how do I achieve that high torque? 2 ways. I use three ways. I use an implant system that has an aggressive thread, a tapered design, so the bi-horizon system, but there's other great systems out there as well. I'll under-prep my osteotomy, and I always aim for bicortical fixation. And finally, in terms of the surgical features, ideally I will always aim to place a straight multi-unit as opposed to an angle multi-unit. That's because a straight multi-unit, we can torque that to a much higher value. So if I give you an example of the bi-horizon system. The straight multi-units I will torque down to 30 newtons, but the angled multi-units for bi-horizons you can only torque to 25. And other systems have variations, but generally, well, actually not generally, all the time, a straight multi-unit you can torque to a higher value than an angled. So obviously, if you take that into consideration, then there's less chance of loosening. Also, something important to note is with a straight multi-unit, you're less likely to eat into crucial restorative space. Angled multi-units are often taller. Again, just from an engineering point of view, they have to be because of the angle correction, and you can eat into valuable restorative space. So just a recap, a wide flap, being respectful of relevant anatomy, but your flap needs to give you access and vision. An alveoplasty, degranulating the sockets if you are removing teeth, looking to place 4 to 6 implants, being aware of what kind of length of implant you're looking to place and what width of implant you're looking to place, aiming for bicortical fixation. For me to achieve my high torques, I'm looking to use the right implant. I am under prepping, and I will aim for bicortical fixation. And when we're talking about minimum torque, look, I aim for somewhere in the region of 45 newtons before I will then decide to immediately load. That's not fixed, but as a general, I aim for 45 millimeters. Now, if we move on, so just before I move on, just note, so obviously you'll be able to watch this video again on Facebook, but I'm going to download it onto my YouTube channel, which I'll put the details on. Ask me questions. I'll do a Q&A at the end, please. Happy to ask questions based around the surgical features of delivering the immediate load full arch bridge and the prosthetic side of the FP3 bridge. So please pop your questions in the comments below, no problem, and I will put this onto YouTube. A lot of people have sent me their email address for the PDF. I'm just getting this series of Facebook Lives together onto PDF, and I promise, I have your emails, I have noted them, I will get them across to you. If there's anybody that has not sent me their email address, then please just pop it in the comments and I'll add it to the list, and you'll get the PDFs of these Facebook Live webinars. Okay, so what are we looking for when we're delivering the prosthetics of the FP3 bridge? So we want to maximise the AP spread and obviously minimise cantilevers for long-term prosthetic success. So trying to achieve maximum AP spread, whatever way that is, either the two distal implants are angled or pterygoids or short implants at the back, but ideally we want to maximise the AP spread with no or minimal cantilevers. We will immediately cross-arch splint on day of surgery. But exceptions. Sometimes it's not always possible, but that's okay. So is there a limit? So if I'm not able to immediately load on the day, for whatever reason, something's happened with the technician issues or etc., then I've got a window of 7 days. A window of 7 days to deliver that immediate prosthetic restoration, because immediate load is not just same day. The definition of an immediate load is anywhere in the region of, I think it's 7 to 10 days or 7 to 14 days. Don't quote me on that, but just check. But it doesn't need to be on the day. But it has to be really before 10 days, and it's all to do with the curve of osseointegration when you get primary and secondary stability, and that's what the numbers come from. The other important thing with your prosthetics, for your prosthetics in your FP3, is your correct restorative space, but that's not going to be an issue because you've treatment planned the case, you've done the correct alveoplasty in the surgical side, so your prosthetics, your immediate and your definitive, will have the correct restorative space. And generally, a lot of my patients are having metal bars with acrylic wraps, and my aim is that magic number of 50. a minimum a sort of a number of teeth. I'm aiming for 10 for an arch. So I will always deliver a 1, 2, 3, a premolar and a 6 as a minimum, and I'll tell the patient that beforehand. I'm always aiming for I'm always delivering a screw retained prosthesis, so that's important. Again, much more for numerous reasons, but a screw retained prosthesis and a prosthesis that's not ridge lapped. Really, really important that we're aware of the fit surface of our prosthesis and how it's going to impact on the long-term health of our implant. So a non-ridge lapped prosthesis, even in the immediate phase of surgery. So the temporary prosthesis is not ridge lapped, and the definitive is certainly not ridge lapped, to allow the patient to maintain that hygiene long term, and for you to examine that as a clinician easier. Now, when we do a lower, often we do what we call an oil rig design on a lower, and especially in high-risk patients. When I talk about high-risk patients, that's your patients with potential medical comorbidities, or they have lost their teeth due to perio disease. We can do an oil rig design. And what I mean when I talk about an oil rig design is it's off the tissue. Now, on the mandible, patients are more tolerant to a prosthesis that's off the tissues by, say, about 1.5 millimeters, and then it really becomes self-cleansing to a degree. But on the maxilla, on your full arch prosthesis, your full arch FP3 prosthesis, you really don't have as much flexibility to leave it off the tissue for about 1.5 millimeters, because what will happen is they'll often come back and complain. They get a hissing, and you'll affect their speech, and they'll come back to you saying, oh, when I'm talking or eating, I'm spitting out, and that's because of the sounds that we make when we speak. The tongue really is crucial in the seal that it makes with the palatal aspect of your upper teeth. So just to recap, we want to maximise the AP spread, either with angled implants plus or minus short implants further back, or pterygoids. Maximise AP spread with a minimal or no cantilever. We want to immediately cross-arch splint, and when I talk about immediate cross-arch splinting, I'm referring to either on the day or up to 7 days for me to deliver the immediate load prosthesis. I aim for a minimum of a shortened dental arch. That's a central lateral canine, 1 premolar and a first molar as a minimum, and I will tell the patients that. I don't know if I mentioned that, but I'm always restoring full arch implant prosthesis to multi-unit level. That's the whole concept of one abutment, one time. I don't want to go back down to the bone implant interface, and I'm bringing that junction that I'm working at off or at the tissue level, and it's certainly, when you work at multi-unit level, helps with the construction of a passive final prosthesis. We're always aiming for a screw retained prosthesis. And finally, I mentioned talking about a prosthesis that's not ridge lapped, and often on the mandible, the prosthesis is off the tissue, and you have more flexibility on the mandible to make a prosthesis that's off the tissue, because it's not as crucial as in the maxilla when it comes to speech. Okay, so I hope that was helpful. That was just a quick run through the surgical features to deliver an FP3 prosthesis in immediate load full arch, and some of the key points in your FP3 bridge design. So I'm just going to quickly go through. I think there was some questions that came up. I really appreciate them. Thank you for everybody for watching. Remember, I'm going to upload this onto my YouTube channel afterwards. I will also construct a PDF of this Facebook Live, and if you have not already, drop me an email. Then if you pop an email on the comments below, I will email them all out to you, the whole series. friend, do you ever use Connor's asking, hi Connor, do you ever use ISQ? No, I used ISQ when it certainly was a bit more new. I tried it out, but no, I just stick to insertion torque. I don't use ISQ at all. Can you expand on the use of LA for elevate? Yeah, Connor, certainly. Good point. We certainly talk about it in my courses that I do and talk about full arch. Local anaesthetic technique is crucial. A couple of reasons. First of all, patient comfort. So you need to be able to give appropriate and effective local anaesthetic so your patient's comfortable. Often these procedures can be up towards 3 hours from start to finish, from surgery to fitting the immediate restoration. So you want the patient to be comfortable. So good effective local technique, and I will use hydrodissection. So short needle in the junction between the attached and non-attached mucosa, and hydrodissection, that means short needle down to bone and pressing, and the pressure of the injection lifts the periosteum off the bone, and that will help in your flap raising. Very important to raise a nice clean flap because you minimise trauma. If you minimise trauma, you get less bleeding, so your visual your vision's not impeded, and your local anaesthetic will last longer if the patient bleeds less, because it's not all leaching out. One of the key things to take away in terms of local anaesthetic is time. Time. Can't emphasise that enough. Give your local anaesthetic, then walk away from the patient. And me and colleagues that I work with, we leave the patient for 10 minutes and we time it, and we're really strict, we time it, walk and come back. And I'm really confident in my ability to give local because I follow a strict protocol in the technique, and I respect the time, give it time to work. So thanks for that question, Connor. So someone's asking me about what do I use for degranulations. You can use these kind of fancy burrs, but usually it's just a stainless steel round bar on the contriangle or straight hand piece, and I just go crazy in the sockets so they're nice and clean and bleeding. When patient can attend routine hygiene post-implant. So hi Mustafa, yeah, so patients, once I deliver the final prosthesis, so that'll be maybe at the 4.5-5 month stage, is then when they really start hygiene treatment, and that's with a water floss or super floss, TP brushes, etc. Thanks Rajan, yeah, great. So if there's not any other questions, I'm going to call it for today, and I will put up on Sunday evening or Monday what I plan to talk about next week on the Facebook Lives on Tuesday and next Friday. Guys, wish you all the best. Stay safe. Look after yourselves and your families. How do you avoid severing the nasopalatal? How do you avoid? Alistair asking, how do you avoid severing the nasopalatal nerve? Is really quite robust, Alistair, and I can only think of one occasion where I've severed it, and I've done a lot of flaps in children, exposing the nerve to remove canines and expose canines, and I've done it once inadvertently on a child and there was no issues. It's quite robust. It's actually quite hard to just sever it in an adult, so I don't think you really need to be worried about that. Just appreciate where it is, and as long as you're directly on bone, elevating onto the bone, that really shouldn't be an issue. Yep, Mustafa, you can hit me with one more question, no problem. Are you typing, Mustafa? You're asking, how do I manage patients with early implantitis? Well, that's a topic in itself. There's so much. But really, it's sort of understanding for me, why is this happening? Is it a prosthetic issue? Is it a biological issue? And really treating the cause first. Is it an issue with the sort of surgical placement? So is it a prosthetic issue? Is it a biological issue? Or was it a surgical issue? You as a surgeon, did you do something to cause it? It's multifactorial. How do you manage it in full arch? Really, I mean, that's a whole different topic. And to be honest, I'm no expert in managing peri-implantitis. Thankfully, I don't see a lot of it because I stick to really strict parameters when I come to placing implants in full arch. I'm really conscious of having adequate bone width. So ideally at least 6 millimeters of width of bone, and I'm placing an implant that's around 4 millimeters in diameter. So maintaining that 2 millimeters buckle, and you know, I like to avoid it rather than manage it. But you know, there's all these either non-surgical or surgical techniques, but I'd be lying if I knew those protocols offhand. I would refer to a current accepted guidelines on that, and I can certainly PM you them, no problem. Any other questions? Guys, thank you so much. Loads of people on, really appreciate the interaction and the questions. Everyone have a great evening. Take care.